Awesome.
Yep.
So thank you guys for joining us. This webinar today is brought to you by Edafio Technology Partners and Compliance Pro Solutions. Today we're going to talk to you guys about the new information blocking rules and the 21st Century Cures Act. So I wanted to just kind of let everybody know real quick. I'm Valerie Mooring. I'm Director of Consulting Services here at Edafio. And Kelly McLendon is our special guest today, our subject matter expert, and he's going to be speaking on all things related to the 21st Century Cures Act and the information blocking rules. Kelly and I met probably around, thanks Kelly, we met around 6 years ago when I first started at Edafio. I was in attendance at the RHIA conference. I heard Kelly speak in person at that conference that year. Shortly after I joined Edafio, and we recognized that we needed a really good partner and platform and application to utilize policy templates and library templates, and really just someone that could help us out on a number of different fronts. I called Kelly, and we've had a partnership with CompliancePro Solutions since then. So again, thank you, Kelly, and really have enjoyed our partnership and leaning in on your expertise when needed. On our next slide, we're going to go through our agenda topics, and then I'm going to turn it over to Kelly to kind of introduce himself and Compliance Pro as well. But today we're going to talk about, again, some of the regulations that you guys are interested in and the reason you signed up for the webinar. We're going to cover some topics around how HIPAA has become a little bit of a barrier, some myths and things like that. We're going to cover Cures Act basics, in addition to some of the information blocking exceptions. And then finally, we're going to close out with some key takeaways and roll through a checklist and talk about information blocking assessments. We are going to allow some time for questions. If you don't mind, please just hold your questions until the end or throw them in the chat and we can answer those as we go through. Kenzie Tickle is here, as well as myself and Kelly, to help answer questions and subject matter expertise around compliance and regulatory topics. So you guys can throw them in the chat, reference a slide if you want. We can go backwards when we get to the end, but we do want to roll through all the slides and the content first so that we can allow time for the Q&A session at the end. We also have a slide filled with references as well that Kelly's really done a great job of pulling together for us. And we will be, of course, recording this webinar and making the slides available to all of the attendees as well. So Kelly, I'll kick it over to you.
Well, Valerie, thank you very much. I appreciate it. And I certainly appreciate everyone that's in attendance today. Thank you. This is the first webinar that CompliancePro and Edafio has performed together, and we're thrilled to do it. They're one of our great customers that we've had for years. Valerie and I and Kenzie have known each other for quite some time and work very well together. And this is a subject that has continually been coming up. So we've all had to figure out how to build strategies for these new rules that have come down on all of us. And so that's what we're really going to talk about today. So myself, I'm a credentialed HIM professional and credentialed in privacy and security, and I've been at this for 45 years. I was actually trained in medical records administration at University of Central Florida and graduated in 1978. So been at it a long time, always worked in the same kind of subject matter area. So, you know, it's interesting to watch, and it certainly has changed in a big way with these rules we're going to talk about today. So let's get into the slides. I do tend to have pretty heavy content slides with a lot on them, but that's really done on purpose so that you can go back and learn a little more depth if you want to later. You can, again, either have the slides or we are also going to have the recording, so you can go back and do it either way. So HIPAA is supposedly going to change. We certainly thought that there was supposed to be the rules were finally going to drop. They put out a notice of proposed rulemaking back like December 21 or December 2020, a long time ago. and that we've been waiting for a final HIPAA rule on privacy to come that's going to introduce a lot of changes in support of the Cures Act, really. But it hasn't been dropped yet, and we thought it was spring of this year, but apparently it may not be. So we don't know. One day we will have a HIPAA rule change update. When that happens, we'll have some more webinars to talk about it, because there'll be some significant changes. But we're not going to talk anything much more about HIPAA today other than how it relates to the Cures Act. But do know that OCR is continuing enforcement, and they've had 41 patient access initiatives, which means patients trying to get their own records or trying to have their records sent somewhere, and there's been some problem with that. OCR has taken complaints on that and then made investigations, and in lots of cases issued penalties. So it's very important to consider patients getting their own records, and to another extent, other disclosures to other individuals. So HIPAA has its enforcement. Now we're moving into the Cures Act. I say regulations for change because we are going to have to change based on regulations that have dropped down. In the past, we had pretty much the Office for Civil Rights to deal with. If someone did a criminal act under HIPAA, they might get the Department of Justice, but it was really the Office for Civil Rights doing the enforcement. That's HIPAA. Now, with the Federal Trade Commission getting into the act for personal health records and mobile device type things that don't fall under HIPAA, and Office of Inspector General and the Office of the National Coordinator of Healthcare IT, I know it's like EIEIO, all these agencies are all getting involved because of the Cures Act, and because of what you will see is going to be the movement towards electronic exchange of patient information on a much higher level than what we've seen before. So we have more federal agencies involved. It's not necessarily a good thing. It gives us conflicting sometimes rules, but that's what we're here for. That's what Edafio does, and to an extent as well, CompliancePro works with these different rule sets and tries to make sense of them. But you're going to have to implement across them, and that's what we're here to help you with. So what is the 21st Century Cures Act? Some of you may be hearing about this almost for the first time, or you've heard about it and are confused by it. That's a typical reaction. We've seen a very slow uptake of this rule over time because it's complicated and they're not yet enforcing it. But they are enforcing HIPAA, so and it's intertwined with HIPAA. What's the Cures Act? Basically, providers and payers have to grant patients access to their electronic, this isn't got anything to do with paper records, their electronic health records without delay or expense. It's intended to provide patients with greater access to their care, their coordination of their care between their different doctors or providers, drive population health analytics, improve outcomes, patient care, and safety. I mean, you know, these are awful big topics to be going after, but that's what the impetus of the Cures Act was. Increase sharing of patient information between appropriate parties and thereby improve patient safety and these other aspects listed here. It's intended to simplify patients' access to their own information on their own medical devices. It's supposed to prevent the blocking of information flowing to the patients. And it does also open the door to non-HIPAA applications that use APIs, which are application programmer interfaces, or ways one computer system can kind of call to another and ask for something like the patient's records. It opens the door to applications like mobile devices that are owned by the patient that don't fall under the HIPAA rule. So now they fall under the 21st Century Cures Act rule, possibly Federal Trade Commission rules. So some more on why the Cures Act was created. Again, giving patients more healthcare data control, facilitating data exchange between providers and payers. Something that we've been struggling with for a couple of decades is how to exchange electronic health information. Much more of that involved with these rules. They're applying information blocking rules to penalize providers and payers that interfere with the access, use, and exchange of electronic health information, especially to patients, but to other parties too. You say, wait a minute, electronic health information, EHI, I've never heard that acronym before. It's basically the same as HIPAA's PHI, protected health information, but in an electronic environment and as subject to these rules. Is that confusing? It's very confusing. So don't feel like you're confused and what are you going to do? We're going to give you more information about that as we go through these slides. They're also going to provide a format for encrypted messages and APIs to safely go out and request data from systems, especially electronic health record systems, but other types of systems too, and ensure that EHRs, the electronic health records, and other data sources, other systems that contain patient information, maybe archive systems, maybe at the payers. The payers with your insurance claims and things like that don't have electronic health records, but they do have systems with records in them. This applies to them as well. Rarely has the government mandated the use of specific automation to promote access to an exchange of something like patient information, but that's what they're doing here. They're giving blueprints and certification guidelines to how to go out and access and exchange patient information in electronic, standardized fashion. The Cures Act itself calls persons and companies subject to its rules actors. That's showing a wider scope of parties that can or must access or exchange patients' health information. So now it's actors. So if you hear that term being used, that means somebody that the rules apply to. Why is that different than, say, HIPAA? HIPAA doesn't have a concept of a patient with their phone having any rules that cover them. HIPAA doesn't cover the patient with their own information on their own phone, but these rules do. So, or at least part of them do. That's why they've decided to call people subject to it actors. Access and exchange are become much more commonplace. You're going to have it happen every day. And you're not necessarily going to be sending records. There are going to be parties requesting records in an automated fashion from you. You may not understand that that's even happened unless you look at some kind of log listing that it did happen. So while we're discussing all of this, remember, it's patient-centric to an extent of them getting their information, but it does cover other parties getting the information from the records as well. So we've got the smartphones, we've got digital applications that might run on computers or iPads or any other. It's innumerable how many other parties might be involved here. And we have to be very careful going forward. So it's a scary time in a lot of respects, but again, that's best handled by being very careful about how you implement these rules. Most patients and a lot of third parties are going to be able to electronically request their information without manual assistance. That's the idea of these rules. You don't want to get in the way of that because you could be accused of being an information blocker. The Office Inspector General already has a portal open where complaints can be logged on people blocking their information. They've had a few hundred so far arrive in that portal. They've done nothing with any of them yet. They're watching, but at some point that's going to turn on and you don't want to be an information blocker. At this point, that could cause HIPAA or OCR to come in and look at the patient access rule if someone's complained about information blocking. So we need to be very careful not to be deemed or complained about as an information blocker. There, again, are no penalties yet assigned. The regulators just say they will apply appropriate disincentives to bad behavior that they consider bad behavior, not following the rules. But again, it's early yet, and this is a massive rule, so it will take probably several years to get full enforcement, and we don't know how much the penalties will be. But the penalties they have in place for EHR vendors that don't follow the rules is significant, 1 million per violation. So they're very serious about this stuff. So the enforcement is coming, and we'll have to be careful to watch that. We'll tell you about that as we go. So there's really two sets of rules that were implemented, the information blocking and the patient access rules. So the ONC, the Office National Coordinator, Health Information IT, the people that run the certification of EHRs, they put out the information blocking rules. Two subtitles, Part 170 and 171. Part 170 is for EHR vendors. You're not an EHR vendor, you're not really interested in Part 170. Part 171, payers, providers, health information networks, health information exchanges, and also the EHR vendors are subject to that. So we're going to talk about information blocking under Part 171. CMS also issued rules that are more about the payers, but they apply also to the providers. So we're dealing with two sets of rules, one from the Office National Coordinator, the other from CMS Medicare, and that makes it complicated because there are two different sets of rules trying to interact and then also interact with HIPAA. It's difficult. So how does it impact? Well, technology, where you have to have interfaces, is really the hardest part of the rule. Now, the good news is your electronic health record vendors, if you are in fact a provider of care and have an EHR vendor, if they're certified, they have to deliver the interfaces for you. So it doesn't mean that you don't get charged something and have licensing, but it does mean that the EHR vendors are helping with the hardest part of the implementation of the rule. So you'll need to talk to your vendors, if you have not already, about their plans as soon as you can. You also need to ensure you've got policies in place and figure out your designated record sets. Now, I'm an old legal health record guy back from the 2006 to 2008 timeframe, even wrote a book on the subject. We don't really deal with that concept of legal health records so much anymore, but it all was based on designated record sets under HIPAA. If you have not figured out your designated record set, which would be the documents or the records in an electronic system that you're going to disclose upon legal request or upon patient request, that's your designated record set. You have to have it as a provider. All the payers have to have it, things like that. So what you want to do is ensure that you have gone through a designated record set exercise. We have been at HIMA put out a task force report. It's coming up on probably almost 2 years now, talking about how to do your designated record sets and giving you samples and examples, all in conjunction with the Cures Act. So that task force report is out there and available to the public. Certainly, we can send you copies if you so desire. It will help you. If you need help, talk to Edafio, and they can help you also with what designated record sets are all about. So you're going to have to understand how your patient portals are going to work in light of the new rule. Just because you have a patient portal doesn't mean you automatically meet these rules. So you'll have to be careful with that. Talk again to your EHR vendors, your portal provider. Usually that's the EHR vendor, could be another party though. And you're going to have to do policies and procedures about the Cures Act. You're going to figure out how you're going to do things like, if a patient asks about technology for health apps on their phone, what are you going to say and how are you going to say it? We've got a slide that talks a little more about that as we go. HIPAA as a barrier. HIPAA's been accused of being a barrier, that we've done our job too well, that we've kept patient information back because we're afraid of breaches and afraid of disclosures that are inappropriate. However, the rules are complex. There is misunderstanding of them. And there have been instances, and that's part of what the Patient Access Initiative from OCR is, where HIPAA has not stood up appropriately or been stood up by the users of it, and they've been a barrier to getting patients or other parties their information. So the net effect's been to limit exchange of patient information. These new rules here in the Cures Act, in the new HIPAA rule, again, we don't know when it might be final. The new substance abuse 42 CFR Part 2 rules all synchronize in the same direction, and that's what they're trying to do, make it easier to have automated access to patient information. It's not to reduce the importance of HIPAA, but relieving some of its burdensome aspects. The idea is to create process automation, allowing a large percentage of what happens in the exchange of patient information to happen with little or no human intervention. And under the Cures Act, if you say, hey, I've got requests, but I don't want to fill the request for a reason, a privacy reason, a security reason, I don't have the way to give it to them in the content or the manner they've requested, you can do that, but you have to invoke an information blocking exception, which we'll talk about as we go here. And how these exceptions are going to be invoked and revoked is a big question in the industry. You're not alone if you're starting this journey now. You do need to start now. The rules are in fact in place, but a lot of organizations are just getting their feet under them. Even major hospital chains are still trying to figure all of this out. So it's time to get started working, but it is not necessarily going to happen fast. Let's look at some basics. So the information blocking is based on EHI, which in this rule is electronic health information. Same thing basically as HIPAA's PHI, protected health information, but it has a wider scope in that, again, it could be the information on a patient's phone. And that isn't covered by HIPAA because it's not a provider of care, it's not a payer. It's intended to provide patients with the means to efficiently export either an entire health record or an entire set of health records. So the days of you were on an EHR, but you can't go to another EHR because you can't get the records out of your initial EHR, those are gone or they're going because the Cures Act rules prevent that. And they demand that either a single patient's records or all of the patients for, say, a provider of care can be gotten under the Cures Act. And that's important to understand because we do see migration, especially in the ambulatory environment, of EHRs from one to another. Now, HIPAA's designated record set, that's the statute number. This is a copy of what it says in the statute. It's really the medical and billing records maintained by a provider or a health plan that's used in whole or part to make decisions about individuals. So if you have documentation relating to any decision made on an individual, that's in your designated record set. What versions of that data and things like that, that's where there's some flexibility and wiggle room on, and that's why you have to define your own designated record set. Every covered entity, every payer has to find their own designated record sets. But again, that's what entities like Edafio and CompliancePro are for. Getting a designated record set exported from systems that might contain part of your records isn't necessarily going to be easy. The EHR vendors are required for certification purposes to follow the law and allow the APIs and the other automated ways of getting information out from their system by other systems requesting through the APIs copies. But if you're not an EHR, getting the information out of those systems requires building what are called FHIR interfaces and being able to handle the API environment as it's prescribed under the law, but there's not any mandate for those vendors to do so. So one of my customers is an archival storage vendor. They have stored hundreds or thousands of shut down EHR systems in their own proprietary system. To get copies out under these rules through the APIs, they're building their own interfaces to do that. Other apps are going to do that. As you create your designated record set, you have to denote which system are you getting the records from. There's no mandate to have all electronic documents. You can have paper documents also in your designated record set if you have to, but best to get everything automated as much as you can. But you're going to have to figure out whether or not you can send out your entire record automatically because you have API access to them. Is this complicated? It's very complicated, but do we understand it? We do, so we can help you to understand it. Don't expect everyone on this call to get this the first time. It's complicated, but again, systems that might contain parts of your record that are not part of your EHR. Let's say you had a lab system. It didn't send information into your EHR. You would have to send the information from that lab system in request for records from patients or other parties, but you may not be able to do it in an electronic fashion. They may not be able to do it in a certain type of electronic fashion. So you're going to have to address each system. You're going to know that your EHR vendors are having to build the APIs, but your other systems, you've got to work with the vendors, and you do the best you can. So I think that covers that slide. Patient education. They're very careful to say that you can only talk so much about third-party applications. Now, your organization may have a HIPAA-based app that they recommend the patients to use or that you recommend them to use. You can tell them that. But you've got to be careful that regardless of whether it's an application you suggest to run on their phones or they bring it up or any other that are out there, you cannot discourage or encourage above just stating the facts about your system or how having a system or a software on a patient's phone that's HIPAA compliant is good for them. You can't really say, this is a bad system, this is a good system, don't use this one. You can't do that. You have to give a consistent, focused, accurate, unbiased, objective, and non-discriminatory description of how it works with electronic records and what the advantage of having HIPAA compliance is. But most of those apps will not be HIPAA compliant because they don't have to be. So your education content, you'll have to work through that. You'll have to train your folks, but it's very important to understand. Let's look at the exceptions. There are 8 exceptions. You must invoke one of these if you're not going to fill a request for information. Now, that might be hard. If the request came in electronically, you would have to know somehow that it's not getting filled by looking at a log. You're going to have to understand how you're going to operate in the new world of there being automation for people coming and getting their own records that you had really little to do with. But if you're blocking someone from getting information in an electronic manner, this doesn't have anything to do with paper records again, you can invoke one of 8 exceptions, and they're listed on the slide. To prevent harm, because you've got a privacy concern, a security concern, it's infeasible for you to do the requests they've made. There's a problem that it'll slow your system way down. And there's 3 others down here: licensing costs and content and manner. Each of these is different. Each of these has different conditions for invoking them. I have done work creating applications, spreadsheets and such, but mostly applications because we're an electronic vendor, for how to manage these exceptions. You may or may not use automation for that, but you will have to figure out how to track whatever exceptions you're going to put into place. I'm going to go over, because a lot of what we wanted to focus on are the information blocking, so I'm going to go over 3 of the exceptions. But I'm not going to go crazy with detail. I'm going to more show you how these slides work. Notice the 3 top boxes: exception name, objective, and reasonable and necessary practices. Those are going to describe the privacy exception, which really is stating that if you have a valid privacy reason for someone not getting the information, you can invoke the privacy exception. It has to meet at least one of the conditions below, and you'll have to track which condition it meets. So that's the privacy exception. The privacy exception is something that you're going to have to factor, as with the other exceptions, into your policies, your procedures, and you're going to have to figure out how it works. If a disclosure is permitted under HIPAA, it doesn't meet the information blocking privacy exception unless, I mean, it's so it is, if it's a permitted disclosure under HIPAA, which means HIPAA calls it out as a permitted disclosure, then it's not going to meet the privacy exception. So you have to be careful about managing both HIPAA and ONC here, or the exceptions. And again, I'm not going to try to get in the weeds here with all the details, but it is important to figure out. Information blocking also has a security exception. So if you're concerned that there's a security risk that you find unacceptable to the systems that are connecting to do this, and that would be something that would have to be determined, and I don't think that's easy to do, you could invoke the security exception. But again, it has its own peculiarities, and much like this slide, has conditions that must be met for its implementation. So you can have a privacy reason, you can have a security reason for not providing information, but it's very specific and you have to meet those exceptions. The information blocking rules are now in effect for the entire designated record set. So the information blocking rules at first did not apply to your entire designated record set, but that time has passed. Now they do. So whatever you define in your designated record set, that is subject to the information blocking rules to the extent that the information is electronic. However, you have to understand too that electronic can include scanned documents. So just because they're in paper doesn't mean you don't scan them if they're requested. You may have to scan them. So that is part of your designated record set that you have to deal with. If you use a release of information vendor, you're going to want to be talking about all of this with your release of information vendor too. For now, how soon do you have to invoke information blocking exceptions? Looks like about a 10-day window, and that's the time frame for getting the information out. If you look at HIPAA, it's got a 30 or 60-day window for providing information, and that could change under the new rule to 15 days. It's still less than the 10 days. So what's going on here? They're speeding up the entire process, basically making the assumption that most of these transactions, if not all, will be automated. I don't believe all will be automated. I believe this is going to be very burdensome to us, but you better be looking at a 10-day window now for invoking an exception if you're not going to fulfill the request. And the exception is under the information blocking rules. And it is unknown how right now do you invoke an information blocking exception, then do you have to take that off later if they resubmit another request or whatever. All that has to be worked out in process. I will say this, we are a member of the Sequoia group, so we think that that's a good way to go. If you're a smaller organization, they're probably not going to be for you, but if you're a larger organization, the Sequoia group has a lot of implementation examples that folks like us use in larger organizations. So just wanted to, the Sequoia Project, I think called the group. But be aware that that is a good reference, and I believe they're in the references. So I'm not going to go crazy again with the rest of the slide here. Your entire designated record set is going to have to be available under the Information Cures Act. And if you're not going to make it available, make sure you have an information blocking exception issued. The content and manner exception is very complicated, but basically means, and this may be the last one you have to fall back on, hey, I cannot give you the information the way you've requested it. I don't have it automated or something like that. Again, here are your three areas of explanation of the exception, and here are the conditions. You have to have one content condition and one manner condition. So it's different. Each exception has different conditions you have to meet in order to invoke it. But this content and manner exception is probably what you will use if you get requests that you cannot fulfill because you do not have the automation to do so. And so again, it's very complicated, but that's the best advice we know so far. That's going to be the biggest, most useful exception for you.
And Kelly, just to kind of recap on those exceptions before we move to takeaways, it's my understanding, it's our understanding currently, correct me if I'm wrong, that on exceptions, each one of those, if you're going to block that information, it needs to be documented in that patient's individual medical record. So that's why we are very cautious about, and want to take extreme concern and care around setting up these processes and policies and procedures properly, because this really does have to be documented in that individual patient's medical record, correct?
Unclear where it has to be documented. That is actually a point of contention. It absolutely has to be documented, but is it documented and placed in your HIPAA folder, in your what now is HIPAA and Cures Act folder for compliance, as opposed to in the records itself, in the medical records themselves? We don't know the answer to that yet.
Gotcha. Yeah.
So it isn't something that's hidden from the patient, but it also isn't necessarily something you have to publish to the patient. So we are struggling to understand it. My best advice right now is keep it with your compliance materials but it could end up, and I know that certain EHRs, and I'm going to call one out, Epic. I don't know about the ambulatory, but I do know that on the inpatient side, I believe you have a tick boxes you can tick off in the record which exceptions were applied. So in that case, it would be in the record, the patient's record, but I'm not sure it has to be in the patient's record. So.
Gotcha. All right, thank you for that. Again, thank you, Kelly. We're going to skip back over to takeaways in the essence of time, because I know we're running a little short on time. I'm going to just kind of roll through these pretty quickly. Kelly covered most all of this in the slides. You guys are going to get the content. So again, you guys can see that the rules, the regulations are big. And so, you know, just starting with understand the relationship of the CARES Act and HIPAA and the information blocking rules is extremely important. Same thing on the checklist items here. Those are kind of going to fold into the next slide where we're talking about this approach that Edafio has decided to take to this, because it is such a large effort. You do have to start somewhere. And so what we've come up with is just a way to get started on this. Is this the end all be all? No, but it's a really great place to get started, assess your current state, help you guys minimize your risk, identify gaps, and provide a roadmap report to help begin you on your compliance journey. This also, we've provided a number of these to a number of our clients within the last 6 months. This really has helped them organize their efforts and rally around the changes that are needed and assign roles and responsibilities to the right people. So on the next slide, what does this look like? Again, it's an information blocking assessment that is a one-time project. We've got a lot more information about it out on our website where you can go out and look at that. And you can request more information about getting one of these started for your organization. Our goal is to complete these in 4 to 6 weeks. And again, what you're getting is a report that is rating your findings as high, medium, and low in order to help in assisting and prioritizing your efforts and remediations. So again, Kelly went over a lot of really important information on these rules and regulations that are in effect now. And we really do want to make this easy for you to get started, because it is a large, massive effort that does involve a number of people. So if you look at the checklist items and things, you know, you're going to have your health information management staff, you're going to need your IT staff. If you have a privacy officer or a compliance officer, those need to be involved. You heard Kelly talking about education. So onboarding new staff, making sure that they understand, you know, what your policies, what your processes look like. Those things are very important. So anyway, that's kind of what this looks like for our information blocking assessments. I did want to allow a little bit of time to just unmute those that want to ask any questions. And again, just thank everyone for joining the webinar today. I don't see questions in the chat at the moment. I don't know if I'm not seeing them.
Mallory, we do have a couple of questions. First one is, if we have different systems that do not interface with our main hospital system, so that documentation isn't on the portal or accessible by the health information department or patient, would that be considered information blocking?
Yes, unless you address getting the information to the requester. If, you know, the request would have to come to you. It wouldn't be a request to the hospital and then they don't have it. That's not how it would work. But if you had a request that came to you, you are going to have to provide the information out of those systems.
And then we have another question. ROI company will send a letter of denial if the information on the request is not enough to fulfill the request. Would this replace these types of documents, or would they be added into the denial for a reason?
That's an extremely good question, and listen to me really carefully. I'm going to try to say this in a way that makes sense to you, but we have to be careful. So there is a great deal of fear and trepidation out there about exactly which of our authorization forms in our release of information processes are not going to apply anymore after, implementing the Cures Act, or are going to apply in a lesser manner. So when we look at release information or disclosure of patient information, especially by release of information companies, how that's going to work and versus what the rules kind of naively are trying to do is make it so that the patient is on their phone and they can go get their patient information from the portal or wherever they can hit the API, and the information goes straight back to their phone. So they haven't requested the record directly from you. So you couldn't use those forms, and you don't have to look at that authorization either. The security of the application is supposedly enough, and you can't invoke those forms. But there are other requester types, especially attorneys, that will try to game this. Now, can the patient give the attorney a link and let the attorney get the information? Yes, that could happen, and there's nothing you can do about it. And can the, how is it going to apply? Because some of these requesters are going to have to, they're not appropriate requesters. You have to have an authorization for them to be released, and you can continue to use your forms. So it's not an all or nothing thing where you're going to get rid of your forms, but a certain percentage, probably a large percentage eventually, of your requests are just going to come in automatically, and they're going to go back out via the APIs. Of the balance of the requests that come to you, I don't see them changing how you do things unless you have to, deny the giving them the records, which would be then in this case, say that they did not have proper authorization and you believe that documentation, you have to tell them so. You would also at that point invoke, if you could, a privacy exception, and you're just going to have to see if that fits. So I'm not going to say you're turning off all of your forms. I'm just going to say this is going to be hard and messy. You absolutely have to do this if you have a release of information vendor in conjunction with them, but they will not lead your process. That's pretty obvious. A lot of them are my customers. I don't believe that they're leading these processes. You lead the process. Some of those forms you're not going to use anymore. Others, you will use them more sparingly. And at that point, you still may have to issue an information blocking exception. The reason we don't know more is just simply because it's so complicated. Not enough data is out there for us to have practices. Everybody's still trying to implement it. Nobody's really saying how to do it right. So other than, the rules, we don't have a lot else to work on. So not a very good answer, I don't think, to your question, but that's probably the best I can do.
It looks like we just had another one come through. Do you have to find a way to track those direct releases for accounting the disclosures?
No. So the direct releases will be tracked by the system that exported them out, the EHR system. But, you've got to make sure you understand their documentation, make sure that you've got adequate copies, or however, if you were going to change from that vendor, would you have to take a copy of the disclosures? Absolutely. So while the vendor may track that stuff, I believe this is something that you're going to want to be able to get in list form on a routine basis, something like that. Absolutely, because you can't trust the EHR vendor with your documentation. I mean, it's good that they'll have it, but they're going to have to produce a list for you, and you probably should store that in your HIPAA folder or whatever, share, on the share drive you have, whatever.
Excellent. Apologize for going over, but this is really great information, Kelly. Kinsey, do you see any other questions in the chat, or anyone have a chat they want to come off of mute to ask?
No additional questions at this time.
Well, let me close, if you would, for my part, just by thanking everyone again for being here. And we hate to be kind of imprecise on a lot of this, but there just isn't practice guidelines out there for us. We know what the groups say, but we don't really know how they're going to implement reality. So, it's really about discovering it and getting into it. But the biggest part is trying to get your arms around it. And that's what Edafio is doing with their process, is introducing it and getting your arms started. It'll get bigger and more complicated from there. And we will probably continue to change the implementation of how we all do things for the next, I'm gonna bet, period of years. But that is in no way a reason not to go hard at it now, because the law is in effect.
Yeah, great advice, great information, Kelly. Again, thank you for preparing this for us today, and always leaning in when we ask for assistance, and appreciate the partnership. Again, thank you as well, everyone, for joining today, and be looking out for recording and as well as slides from today's webinar. Thank you again for joining. Hope everybody has a great day.
Thank you.
Bye.